lucky and privileged to have another master in the field of nephrology to discuss the novel biomarkers in CSA-AKI. So Dr. Annabelle C. Lim graduated cum laude in BS Medical Technology in University of San Tomas and likewise a cum laude in Doctor of Medicine in the same institution. She had her residency training program at St. Luke's Medical Center, Quezon City, where she became a chief president, and her fellowship training in the same institution, where she was likewise a chief fellow. She is an active consultant at St. Luke's Medical Center, Quezon City and Global City, and had become my training officer when I was a fellow in training on 2017 to 2018, for which I will be forever grateful to her and indebted. She later became a training officer of Department of Internal Medicine, St. Luke's Medical Center, Global City on 2020, and presently the hardworking and dedicated training officer of Department of Internal Medicine, St. Luke's Medical Center, Quezon City. So with so much excitement and anticipation, I will now turn over the floor to our master class lecturer, Dr. Annabelle C.
Thank you, Rachel, for that kind introduction, and uh, I hope to live up to that excitement. So should I share my screen now, or you'll be the one to share my screen? Share.
You can share your screen, Dr.
Okay. Okay. Good evening, everyone, and thank you for joining me here tonight as I discuss on the novel Biomarkers in Cardiac Surgery, Acute Kidney Injury, Conceptual Paradigm to Clinical Use. The objectives of this topic would be as follows: to determine the relevance of novel biomarkers in risk assessment, prevention, diagnosis, management, and prognostication of patients with CSA-AKI, and to integrate in clinical practice the use of these biomarkers in improving the outcomes of cardiac surgery-associated AKI. The word biomarker was first coined in 1989 by the Food, Drug, and Administration to mean any diagnostic indicator that can be measured and used to assess risk or disease. Currently, we have been using three criteria for diagnosing AKI over the past decades, although now we are using KDIGO scoring system, the KDIGO criteria for AKI. But what is common among all these three is the use of creatinine and urine output as the biomarker. This slide merely shows to you how we now define cardiac surgery-associated AKI, which is not really any different from how we classify, in general, acute kidney injury. Now, our use of creatinine had repeatedly been scrutinized and compared with the evolution in cardiac diagnostics. As shown in this slide, over the past decades, cardiac diagnostics had undergone profound changes from the WBC count that they used in the 1950s to what is now the gold standard in diagnosing acute myocardial infarction, which is troponin I. In stark contrast, in the realm of nephrology, we're still using the same biomarker, which is serum creatinine, in the diagnosis of acute kidney injury. Now, the evolution in cardiology, as we know, had led to multiple therapies that had resulted in a 50 to 70% reduction in mortality. On the other hand, in our case, we only have supportive therapies with high mortality rate. Now, speaking of mortality rate, for cardiac surgery-associated AKI, the in-hospital mortality rate is as high as 20 to 50%. Now, why is this important? Because the second most common cause of acute kidney injury is actually after cardiac surgery, with an incidence rate of up to 39%. And between 3 to 6.5% of these patients would undergo kidney replacement therapy. Severe cardiac surgery-associated AKI is also independently associated with a 3 to 8-fold higher perioperative mortality, prolonged length of stay in the ICU, and as well as increased cost of care. Now, this slide just merely shows to you how the lines would diverge in terms of survival for patients who have no AKI versus those who have severe AKI. So those patients who don't have severe AKI would have a poorer survival or a higher mortality rate or cardiovascular disease as compared to those who don't have any AKI. And it is not just the severity of AKI, it also is in the duration of the AKI. So somebody who has a more than 7 days of AKI would have a worse prognosis as compared to the one whose AKI has resolved in a matter of 1 to 2 days. Now, this shows to us that those patients who develop postoperative AKI would incur a hospital cost that is 159% higher than those patients who also did not suffer AKI. So that's a lot of money spent just because of cardiac surgery, acute kidney injury. Now, if you want to go by numbers, then this is an interesting data showing that for each 1 milligram per deciliter increase in creatinine is associated with a 5-fold increase in AKI. And when the baseline creatinine is 2 to 4 milligrams per deciliter, the patient's risk for post-operative dialysis after AKI would reach about 10 to 20%. A pre-operative creatinine level of above 2.5 milligrams per deciliter would increase the risk for mortality and also prolong the length of hospital stay. Now, this grim picture that has been attributed to the delay imposed by the rate of rise of creatinine in response to the abrupt loss of glomerular filtration rate. As such, using creatinine as a gold standard in acute kidney injury has several pitfalls. First, a large amount of renal mass can be lost without appreciable changes in serum creatinine level. Two, the rate of rise and the peak steady state of serum creatinine in patients with AKI vary individually. Three, serum creatinine is influenced by non-renal factors such as total body volume, muscle mass, and even protein intake.
Recording in progress.
And more specifically to cardiac surgery, there is such thing as cardiopulmonary bypass-induced hemodilution, which further decreases the serum level of creatinine. Thus, the avid search for a better biomarker, that ideal biomarker that would be the equivalent of cardiac troponin. And this quest had led us to the identification of different molecules, as here in this slide, that emanates from the injured kidney or those reflecting altered kidney function. These molecules may range from constitutive proteins released by the damaged kidney or to molecules that are upregulated in response to injury or even to non-renal products that are filtered, reabsorbed, or secreted by the kidneys. To explain how these biomarkers would accumulate in the plasma and urine, Mortensen showed us this illustration representing the different pathophysiological events during the process of kidney injury that results in the accumulation of these biomarkers. Foremost is the increased synthesis in the extrarenal tissues, such as what we see with NGAL. Aside from that, there is also the release of these biomarkers from circulating immune cells, and as well as when there is impaired reabsorption of the proximal tubule, thus causing these biomarkers to increase in level in the urine. Again represented here by NGAL, but also by cystatin C. And when there is secretion of biomarkers from activated immune cells migrating into the lumen, and also when they are induced by tubular epithelial synthesis in the different parts of the nephron. Now, one of the caveat about this is that when you understand how these these biomarkers accumulate, is that you would see that these may come from secretions that may not be totally related to AKI, that this may actually be some response to systemic inflammation like sepsis or a major surgery or trauma. Now, for practical purposes, the pioneers of the biomarkers, the field of biomarkers like Ronco and Kellum classify these biomarkers into three types: stress biomarkers, damage biomarkers, and dysfunction biomarkers. Kellum would always describe stress biomarkers as like the psychiatrist of the kidney, because the stress biomarkers would be the first to sense when the kidney is already being attacked by any exposure. Now, during this time, called the cellular stress, the condition is potentially reversible and cell damage might not or might have occurred. And for cellular damage, this would be characterized now by alterations of cell metabolism and expression of adhesion molecules. And if this injury persisted, such as when these cells, these exfoliated viable cells, would block the lumen or cause necrosis and apoptosis of the tubular cells, then that is the time when the dysfunction biomarkers will be elevated. So to group it, this is how it's grouped. So stress, damage, dysfunction, and these are the representative biomarkers for each of the classification. There are actually 35 to 40 biomarkers that we know of, but for the topic tonight, we will only be discussing three or four of these biomarkers. And I chose this primarily because these are the biomarkers that are widely studied, that would have most evidence in cardiac surgery, acute kidney injury, and the one that is available in the country. So let's expound more on each of these biomarkers. And let's begin with the stress biomarkers. Stress biomarkers are also known as pre-injury or cell cycle arrest biomarkers. This is represented by these two molecules: the tissue inhibitor of metalloproteinase 2 or TIMP2, and the insulin-like growth factor binding protein or IGF-BP7. Together, they are branded as NephroCheck and is USA FDA approved. Now, how does this work? Well, each cell has four stages that they go through, and that they have to go through this tightly, meaning to say that each cell must enter each phase on schedule in order to divide and repair. Otherwise, the normal division and repair process will be maladaptive. So imagine this as the renal tubular cell. Now, what happens if, let's say, the cell remains longer in the G1 phase or in the G2 phase? Then what will happen is that the cell will produce a phenotype that is considered hypertrophic, senescent, or fibrotic, which of course we know is not good. Now, conversely, what if the cell exits immediately from one of these phases? Now, from one of these phases, then the cell would that would then lead to cell apoptosis. Now, what happens to the kidneys when it is exposed to stress or injury? When the kidney senses a form of stress, we have these two molecules, the TIMP2 and the IGF-BP7, that are stimulated. In turn, they would stimulate these P proteins, which would then block this complex known as the cyclin-dependent protein kinase complex. When this complex is blocked, it would result in a transient G1 cell cycle arrest. So this cell cycle arrest, meaning to say it would stop there for a while, because that would give the cell some opportunity to repair the DNA damage and for it to regain some function. Now, this process usually happens early in the cellular stress and may help actually the cell maintain energy balance. But what happens when this cell cycle arrest is sustained? As I've said earlier, it would lead to a senescent cell type phenotype or even to fibrosis, such that it has been thought that this can be the mechanistic link from the transition from AKI to chronic kidney disease if the injury is persistent. Now, what about damage biomarkers? Damaged biomarkers are also known as tubular or inflammatory markers, biomarkers. As I've said, for our topic tonight, we will be focusing on NGAL. But why did I highlight this other biomarker known as liver fatty acid binding protein? Well, it's because one of our fellows, Dr. Carlo Buado, will be working on this biomarker, and we hope to hear from him when he finishes his topic. But for now, for damage biomarker, we will be focusing on NGAL. NGAL is short for neutrophil gelatinase associated lipocalin. And because NGAL is the kidney's ready to go gene, meaning to say when the kidney is stressed, it secretes a lot of these molecules or this gene. That's why for a time it was thought that NGAL will be will be the equivalent of the troponin for cardiologists. NGAL is actually a small 25K Dalton protein that is produced by the neutrophils. It exists in three different molecular forms and is actually expressed not just in the kidney epithelium, but also in the colon, trachea, and lung. It is a small siderophoric protein, meaning to say it is involved in iron transport to and from the cell and acts as a bacteriostatic agent by sequestering iron. NGAL is freely filtered in the kidneys. So what happens when the kidneys are healthy? NGAL is formed by multiple cell types at low levels. It is not. It would then circulate systemically and undergo glomerular filtration. It would be reabsorbed via the megalin pathway in the proximal tubule, but still you would see some low levels of NGAL in the urine. But what happens when the kidney is stressed? When the kidney is stressed, as I've said, NGAL is the ready-to-go gene of the kidney, which means to say that it's rapidly expressed by kidney cells, mainly by the thick ascending limb and by the collecting ducts of the nephron. It is detectable in the urine as early as 3 hours after the injury. And proximal tubule may even secrete some of this NGAL in response to the depletion in ATP. As I've mentioned earlier, NGAL is not just found in the kidneys, it may also be found in other organs, such that when the body has some form of inflammation, the production of NGAL is upregulated, such as in the case of sepsis and malignancy, and couple that with the decreased GFR, then we see NGAL increasing in the blood. Also, because NGAL are found in the neutrophils, we see that when there is urinary tract infection and there are white blood cells in the urine, it might also release NGAL, thus causing a falsely elevated NGAL in the urine. Now, what about functional markers? Functional markers are also known as filtration markers. This is best exemplified by creatinine. And for our discussion tonight, we'll be focusing on cystatin C. Although we know that there's a new one that was discovered, the proenkephalin, which is an endogenous polypeptide hormone in the adrenal medulla and nervous system, but which is not what we will be discussing because it's still quite new. Functional markers have no known functional role in the kidney. So cystatin C, as exemplified by this filtration marker, is a 13K Dalton proteinase inhibitor. Actually, it is more than 100 times larger than the creatinine. It enters the proximal tubule by glomerular filtration. It is produced at a constant rate by nucleated cells, and it is not reabsorbed to the systemic circulation after filtration. It is minimally protein-bound. It has a half-life of 2 hours, which is merely half of that of creatinine. So creatinine has a half-life of about 4 hours. Thus, once renal function fluctuates, the serum cystatin C changes may be earlier than serum creatinine. So this characteristic of cystatin C to 1, 2, 3, 4 is touted as the reason why it may be a better biomarker than creatinine. But cystatin C is also affected by other conditions. So except for hypothyroidism, all these conditions mentioned here may cause a false elevation of cystatin C, thus underestimating eGFR. This slide would just emphasize to you the time of appearance of these biomarkers and their peak levels. So for TIMP2 and IGF-BP7, it immediately appears after cardiopulmonary bypass, but would peak at about 6 to 24 hours. For NGAL, it would appear less than 4 hours after cardiopulmonary bypass and peaks at about 4 to 6 hours. Now, the study of biomarkers from their discovery to its possible clinical application benefits had spanned decades. Indeed, we can say that the journey had been long. And I actually, while doing this topic, I actually remembered that this was also the same topic that was first assigned to me after I graduated from the section of nephrology. And from then to now, it seemed like we still have the same question, and that is, are biomarkers ready for clinical use, or are they are just used? I mean, they're just good for research purposes. So I hope that in the next slides, we can learn together and see if the time has come for biomarkers to be used in clinical practice. Now, to divide the talk, I actually break the next few slides, the next minutes of my talk to these three topics. So I would start with discussing the milestones in AKI and of biomarker-based definition of AKI, followed by the supporting evidences on the clinical application of the different types of biomarkers and the potential benefits of these biomarkers. I think the topic on biomarkers in AKI will not be complete without a brief history of how our knowledge on AKI has evolved from acute renal failure to acute kidney injury. And in summary, I think there are three important milestones. First is the awareness or the knowledge that AKI is a spectrum. Number two, when we found out that there's such a thing as subclinical AKI and that it has some impact to patient outcomes. And finally, the realization or the reckoning that no one biomarker fits all facets of AKI. Now, it used to be that we look at a lot of kidney insults as just one isolated event, thus the term acute renal failure. But it was this knowledge that rather than an isolated episode, acute kidney insult is a consequence of progressive events that lead to progressive deterioration of kidney tissues and eventual decline in renal function. Unfortunately, due to the rate-limiting step of creatinine production and release by the skeletal muscle, the creatinine as a biomarker is not able to detect this early spectrum of kidney injury. As you know, creatinine only increases when about 50% of the renal mass has been damaged, and it takes about 2 to 3 days before the creatinine goes up from the onset of insult. And this lag time between injury and the resulting elevation or the loss of function is actually a missed therapeutic opportunity and may actually be that narrow window of reversibility for which stress or damage biomarkers may be most useful. Besides, we also know that creatinine does not differentiate between the structural kidney damage and functional hemodynamic triggers. Thus, with the use of functional and damage biomarkers, it is hoped that we can actually expand our diagnostic criteria of AKI from what is current, such that the Acute Disease Quality Initiative conceptualized this framework of AKI using novel biomarkers. that combining both biomarkers, the possibilities are as follows. First is that creatinine and the biomarker may be both negative. Second, here in the right upper quadrant, that creatinine is still negative, but the biomarker is already positive. And third, the creatinine is positive, but the biomarker is negative. And then fourth, that both are positive. Now, the idea is that at any given point in time, patients would fall into one of the four quadrants based on the changes in the representative functional and damage marker test. Now, what does this imply to our clinical practice? Well, it is worth mentioning that one of the pioneers in the study of biomarker named Haas mentioned that about 15 to 20% of our patients do not actually satisfy the present criteria of AKI. So that has now been called subclinical AKI, which represents acute tubular damage in the absence of functional acute kidney injury. And this acute tubular damage is a pathological process that is separated in time from serum creatinine-based dysfunction, which is not always manifested by the present criteria that we use. Thus, it further strengthens the position that one biomarker doesn't fit all. On the other hand, if you look at the left lower quadrant, wherein the markers of GFR changes may already detect hemodynamically mediated decreases in glomerular filtration rate, but there's absence of significant tubular injury. Logically, therefore, examination of multiple biomarkers may inform us not just of the likely occurrence of AKI, but its nature, extent, and pathogenesis as well. Likewise, I think with the use of biomarkers, it will improve our ability to further delineate what we consider currently, which is very nonspecific, the syndrome of pre-renal azotemia, which has traditionally been equated with volume responsive and reversible alterations in kidney function. Because on this quadrant, where we only see changes in function, it may also group the traditional post-renal category under this domain, thereby focusing now our attention on the potentially time-sensitive reversibility of the underlying lesion before the damage occurs. Furthermore, when we sequentially assess the functional and damage biomarker, it would allow us to track the course of AKI and provide information on the events and the potential mechanisms involved, such as in the case of advanced stage of urinary tract obstruction, which would fall under what we know now as ATN, and but which using this quadrant would actually fall under this quadrant in the right lower quadrant. But combining these biomarkers would of course add some challenges to us, because it would also mean that the net signals that will be given us would be in different directions. For example, if biomarker A is already elevated but biomarker B is still normal, or vice versa, then that is now again something that we would have to find out, like what's really happening to this patient. And then given the dynamic nature of AKI, these sequential changes would make us consider what is the initial reference point. So we would want to know how it all began. So thus, maybe we would be more attentive to the surveillance or to screening our patients when we anticipate an insult. Now that we're done with the first part of this topic, we move to the second part, which is the supporting evidences on the clinical application of different types of biomarkers. Now, last year, the Acute Disease Quality Initiative published its recommendations on AKI biomarkers, on how these biomarkers may be integrated in clinical practice. And the panel focused on these four broad areas, namely acute kidney injury risk assessment, prediction and prevention, diagnosis, etiology, and management, as well as progression and kidney recovery. So following the lead of ADKI, I will be citing evidences or the lack thereof on these four areas in the aspect of cardiac surgery associated AKI using the three biomarkers of our interest, such that in the next slides that I will be showing, they would basically be answering this question among patients undergoing cardiac surgery. Are there evidences to support the use of NGAL, TIMP2, IGFBP7, or commonly known as NephroCheck, and cystatin C in the four broad areas of interest that ADKIS is advocating, such that the framework for each for such that the framework will be that for each area of interest, let's say risk assessment, I will start by citing the consensus statement by ADKI, then the evidences for each of the biomarkers. So let's begin with consensus statement 1 and 2 on risk assessment. So consensus statement 1 and 2 states that the decision to perform a kidney health assessment to gauge AKI susceptibility should integrate patient factors, demographic characteristics, comorbidities, previous AKI episodes, with the expected intensity of a planned exposure that carries AKI risk. So in this case, in our case, that's cardiac surgery. It followed it with that the types of functional and or damage biomarker evaluation to be performed should be driven by the results of the kidney health assessment for AKI susceptibility. So both has an evidence of grade B, strong recommendation. So just for orientation, grade B means that further research is likely to have an important impact on our confidence in the estimate of effect and may change the estimate, whereas a strong level of recommendation concerns an intervention or action that most patients would want it, that most clinicians would recommend it, and it can be adopted as a policy in most situations. So in the setting of cardiac surgery, which carries a high risk for AKI, what is or are the evidences for using these biomarkers in risk assessment? So this is an early study, and I think this is the only study so far that looked into the discriminative ability of preoperative biomarkers for AKI risk stratification alone or when they were added to a clinical model. So this is a single center prospective cohort involving 110 patients undergoing cardiopulmonary bypass surgery from 2009 to 2010, with the primary endpoint of diagnosing AKI within 72 hours of surgery. Its secondary endpoint is to evaluate multiple biomarkers and compare them with known risk scoring systems in cardiac surgery, such as what we use, which is the Cleveland and Euroscore. Now we know that Cleveland scoring system offers the best discriminatory power to predict dialysis requiring AKI, while Euroscore was originally developed to predict perioperative mortality risk following cardiac surgery, but has shown very good discriminatory ability in predicting post-op AKI. And for this cohort, Euroscore defined 73% of AKI patients as high risk, and none of the patients belonging to the low-risk group developed AKI. Whereas for the Cleveland scoring system, it classified only 16% of patients as having AKI. Now, I just want to show you this slide that for this study, among the biomarkers, plasma NGAL has the best area under the curve value for early diagnosis of AKI after surgery. But that is not so when they look at the preoperative biomarker for risk assessment. In fact, NGAL is just number 5, so only it's below cystatin C, it's below creatinine. Now, when you look at the AUC curve of these biomarkers individually, it is not different from using the scores or the Cleveland score or the Euroscore in risk assessment. So meaning to say they are just individually they're similarly effective. It is only when you combine the score or the biomarker with the score that the predictive performance actually improves. So when you combine creatinine with the score, the NGAL with the score, cystatin with the score, and that's the only time that their predictive performance actually increased. And this improvement was actually better with the Euroscore than with the CCF score. Now let's move on to consensus statement number 3, still on risk assessment. We suggest that biomarkers of acute damage not be interpretable prior to kidney insult and should not be used for AKI risk assessment. It has a grade A strong recommendation because it is unlikely that patients scheduled to undergo nephrotoxic exposures, elective surgery in stable conditions, will meet the criteria for kidney stress or acute damage to be predictive of the subsequent AKI. Now let's move on to another area of interest, which is AKI prediction and prevention. So this is covered by consensus statement 4 and 5. We recommend using validated biomarkers to identify patient populations for whom preventive interventions have been shown to improve outcomes with a grade A and strong recommendation. It was followed by we suggest combining clinical assessment and validated biomarkers to triage patients and optimize the timing and type of interventions designed to improve processes of care and patient outcomes. Although this is grade C, it received a strong recommendation. Now let's move on to the evidences in cardiac surgery, acute kidney injury. So this is the very famous PREV-AKI trial. I say famous because this is the one that is most often quoted now in the world of biomarkers. This is a randomized trial that involved 267 patients that used NephroCheck or this stress cell cycle biomarkers, TIM2 and IGF-BP7 as the point of care test. It was taken 4 hours after cardiac surgery and it was used to identify high-risk patients for CS-AKI. Now, for those patients who become positive to the test and the cutoff level that they use is 0.3, then they would be randomized to the protocolized care versus the standard care. Now, what is this protocolized care? The protocolized care involves using this KD-GO bundle for the prevention of AKI. As you can see here in the slide, it involves renoprotective strategies like optimizing volume status and perfusion pressure, avoidance of nephrotoxic drugs, and even prevention of hyperglycemia, among others. Now, what did it show? It showed now, what did it show? It showed that in 72 hours, AKI was significantly reduced. So the reduction is about 17% in AKI. And for moderate and severe AKI, the reduction is about 34%. Unfortunately, we still don't have this biomarker in our country, but at least it tells us that it is possible to reduce that inevitable risk of AKI among patients who undergo cardiac surgery. Now, what about diagnosis? So this is consensus statement 6. We suggest that a combination of damage and functional biomarkers along with clinical information be used to improve the diagnostic accuracy of AKI, to recognize the different pathophysiologic processes, to discriminate AKI etiology, and to assess AKI severity. So this has an evidence of grade B, but the level of recommendation is just conditional. Now, what is conditional in this case? It is that the desirable effect of this recommendation probably outweighs the undesirable effect, but that the panel is not confident about the exact trade-offs. Now, this recommendation brings us back to this conceptual framework of AKI that we mentioned earlier. And using this conceptual framework of AKI, the ADKI group actually came up with their proposed expanded diagnostic criteria of AKI using biomarkers, whether or not they're positive or negative, and subdividing the stage with A and B. So, for example, for stage 1A, so for stage 1S or subclinical, the biomarker is positive, but none of the creatinine or urine output has changed. For 1A, the biomarker is negative, but there's already a change in either the creatinine or the urine output. And stage 1B is the biomarker is positive, but and at the same time, there's also a change in the creatinine and in the urine output, such that the expanded diagnostic criteria would actually look like this. Now, at this point, I think the question that runs in our heads is that, but are these biomarkers, the one that we are talking about, like NGAL, NephroCheck, cystatin C, are they sensitive or specific enough to diagnose early stages of cardiac-associated acute kidney injury for this to actually work? So let's start with the evidences on NGAL. So these are all the studies on NGAL among patients who underwent cardiac surgeries. Needless to say, they are both the plasma and the urine NGAL has been widely studied. The first study on NGAL was actually done among children undergoing cardiac surgery, and it yielded a fantastic area under the receiving operating characteristics of 0.90. And because of that, it actually stimulated a lot of studies on NGAL that expanded to the adult population. However, a lot can be said about these studies or the results of these studies. As you can see, in terms of the population size, you have very small sample size. Number two, different studies also use different definitions of AKI. And number three, that the AUC of these studies were actually not consistent, and they were usually just highest among children. Besides that, there is also lack of specificity in the NGAL assays. A meta-analysis was actually published in 2016 that involved 22 prospective cohorts and 2 retrospective cohorts. And these studies spanned from 2005 to 2014. It totaled about 4,066 patients, of whom 26.3 patients were diagnosed to have AKI. As expected, plasma was more discriminative than urine. Children fared better, when NGAL fared better among children population than adults. And if you look at the AUC here, it wasn't really that bad. So it's 0.83. But how come this meta-analysis did not push the field forward for NGAL? Well, I think primarily because the sensitivity of the test was not high enough. Number two, that there was certain degree of publication bias that was found. But more than this, I think it's because different cutoffs were used in the enrolled studies. And actually, it created more confusion than answers. That's why up to now, we still don't know whether NGAL is a good marker for us or not. Now, another meta-analysis on biomarkers was done, but this time involving different types of biomarkers. So as you can see here, it now had aside from plasma NGAL, they checked urinary, so urinary NGAL, urinary cystatin C, among others. And whether it's in the urine or in the plasma, as shown in this forest plot, you can see that the AUC is just 0.7, so it's quite modest. And so with these two meta-analyses, the conclusion was that that AKI actually has multifactorial etiology, even if you're talking about just one event, which is cardiac surgery. Thus, it is very unlikely that one single biomarker, such as NGAL or cystatin C alone, will give sufficient high sensitivity and specificity. Thus, moving forward, as we have new studies and maybe taking a cue from all those old studies, we have this study published in 2018. It's a prospective cohort study of consecutive cardiac surgeries from 2014 to 2015 in a single center. Its population is not that big. There's only about 69 patients involved in this study. But I think that this study is worth mentioning because the difference of this study is that it made sure that all those patients who will be included in their study have at least two risk factors for AKI, and that they did not simply check the absolute value of the creatinine or the NGAL, but they actually compared the change in the NGAL from pre-op to immediately post-op, or about 10 to 18 hours, and that goes with the creatinine as well. So what they did was compare the absolute value and the changes and then combine the two. And it showed that when you actually combine the ratio of NGAL and the ratio of serum creatinine, that its diagnostic ability actually improves. So here, the specificity of the test actually increases when you combine the two. And when they talk about the difference, what they found as the optimum cutoff is when there's a difference of about 100 from pre-op NGAL to post-op NGAL. And when it comes to creatinine, the relative change value in creatinine is 14%. That's why this is what they mentioned here. Now, this is consistent with an earlier study by Proll, wherein it actually did the same thing, but it used more and different types of biomarkers. So, but basically grouping them into tubular biomarkers and those biomarkers that potentially reflect glomerular filtration rate. So here, one of the tubular markers that they used was the urine NGAL, and the one that Carlo Boado is working on, the L fatty acid binding protein. And for the filtration biomarkers, it used hepcidin as well as cystatin C. So when they worked on all the combinations, they found that the best combination involved one biomarker of tubular injury, let's say NGAL, and then combined it with one filtration marker, which in this case was cystatin C, or one biomarker that can be measured early and one that can be measured later in the post-operative course, which actually fits the characteristics of these biomarkers. Like NGAL usually is taken earlier than creatinine or cystatin C, which is taken at a later time. Now, speaking of cystatin C, we now move on to this meta-analysis that involves cystatin C among patients who this meta-analysis is across all settings of acute kidney injury. So this was published in 2017, involving 30 prospective cohort studies with 4,200 patients in 15 countries. 23% of these patients developed AKI, and majority, more than a third of those AKI were actually related to cardiac surgery. And we see that cystatin C overall would have a very good discriminatory ability of 0.89. And when they did a subgroup, it showed the same thing for CS-AKI, which is also at 0.89. And when they further subdivided their analysis to include the time points from extraction of cystatin C, they also found that it was this 12 to 24 hour after cardiac surgery that is most diagnostic, with the higher AU curve of 0.9. As such, it has been suggested that if we put this in practice, that it might be best to determine serum cystatin C 12 to 24 hours after cardiac surgery or after the AKI inciting event. And by the way, for this meta-analysis, the cutoff that they used is a change in serum cystatin of 50%. So if there's a 50% elevation of serum cystatin C from baseline, then that is diagnostic of AKI. Now, still on cystatin C, I just want to show this slide to show you a fairly recent study published in 2019. It's a prospective cohort involving 628 patients who underwent elective cardiac surgery. So what actually just want to highlight here is that when they also did the cystatin, they also took the cystatin C at the 10th hour. And what they found out is that for patients who have AKI, this cystatin C from that 10th hour will continue to be elevated up until the 72-hour mark post-operative. Whereas for those who did not develop AKI, this value would go down. So you see that for those who don't have AKI, the value keeps going down. But for those who have AKI, it continues to be elevated up until 72 hours. It also divided the level of cystatin C into several quartiles. And as you can see here, there is a graded relationship of cystatin C with the risk on the quartiles with the risk of AKI, with the lowest quartile having 9.8% risk of AKI and the one with the highest quartile having a 64.5% risk for AKI. And when they added this level of when they added this level of cystatin C, the 10th hour mark, to a risk modeling's a prediction score that they did, it actually also improved the prediction ability of this model that they used in their setting. Now, I just want to show this slide just to highlight that the timing of the test is just as important as the biomarker itself. So we've been seeing how cystatin C was becoming diagnostic or were diagnostic from 10th hour or from the 12 to 24 hour onwards. And this is one study that shows when they used cystatin C on the 3rd hour, it actually did not show any difference between those who developed AKI and those that did not. Now, there's another study. This is more actually a prognostic study, but just to mention that if the meta-analysis was using a cutoff of 50% as something that's diagnostic for AKI, this more recent study was using a cutoff of 30%, and it says for them, they use it because they found it to be most optimum in their center. So I think it's still something for us to figure out whether it's really 30% or is it 50% from baseline. Now moving on to evidences on NephroCheck, which is TIM2 and IGF-BP7. These are all the trials on cardiac surgery. And as you can see that in terms of their discriminative ability, it would also vary depending on the studies. But a meta-analysis was done, and it was published in 2018. It involved 10 studies, and what they actually did here was to make some subgroup analysis. So the pooled AUC is about 0.3, so pretty good. But if they subdivide it to not to just include all stages, but to just include 2 to 3, then the sensitivity and specificity of the test goes up. And in terms of time of measurement, if you continue to check NephroCheck, to continue to take it, these 2 biomarkers, then its AUC also improves as time goes by, up until 24 hours at least. Basically, this is just to show us that when they did another meta-analysis, but just involving urinary biomarkers of TIM2, insulin growth factor binding protein, and NGAL, it actually showed us what is already obvious, that NGAL, most of the tests which has an AUC above 0.8 were actually done in pediatric population. So the 78% here was because they were all done, because the results of the yielded 0.8 were actually pediatric population. And that for TIM2, 50% of the studies actually yielded an AUC of above 0.8, and for the other 50%, it was 0.7. So fair values to diagnose AKI. So I've said a lot over the past few minutes, and this is the summary when it comes to the diagnosis based on the evidences that we have gathered. So plasma and urine NGAL is more discriminative, it seems, in children than in adults. That urinary TIM2 and combined with insulin growth factor binding protein 7 is more discriminative, it seems, in adults. The best combination is a combination of a stress or damage biomarker and a functional marker. That the cutoff for TIM2 and insulin growth factor binding protein, so they're taken together, known as NephroCheck abroad, is 0.3. For cystatin C, it might be 30 to 50%. And for NGAL, in terms of absolute value, it's 150 nanograms per ml. But when it comes to change, then it's about 100 change from baseline to post-op. And that, remember that these are time sensitive. So if you take them too early, they might not show any discriminative ability to predict AKI. For cystatin C, it seems like the period is about 10 to 24 hours. For consensus statement 7, so at least we know we're halfway because the consensus statement is 11, and I'm trying to rush because I don't want to take too much of your time. But I think this is one of the more important things when it comes to the use of biomarker, that we suggest that a combination of biomarkers may assist in the planning of therapy and management of AKI. So the level of the grade of evidence is C, and it is just conditional. But it mentioned here that what it actually meant is to have biomarker-guided algorithm and goal-directed management protocols. So what if this is actually put in place? And what if there's actually a nephrology rapid response team as what is being envisioned by our AKI experts? So how does this nephrology rapid response team work? So this is how they envision it to work. So the primary physician who sees the patient would triage this patient, whether they're low, high, or moderate risk, using these steps they call the Fantastic Four. So F1, as shown here, would mean would consider the clinical scenario where the patient's signs and symptoms and the surrounding circumstances and risks are reviewed and considered. So in our case, that would be having a cardiac surgery or a coronary angiogram. Then F2 would be interviewing the patients or the relatives to review the past history with the aim of identifying some level of susceptibility or intensity of exposure. So does this patient have previous history of dialysis? And now, I think more importantly, in light with the times, we know that having had COVID is now a risk factor for CKD or AKI. So we might have to put history of COVID in F2. And F3 here is about physical examination. So it aims at characterizing their hemodynamic instability, whether they're volume depleted, they're fluid overloaded, or if there are any signs of infection. And finally, on F4, it is the laboratory results, including the possible use of AKI biomarkers to complete the patient risk stratification. And when patients are considered high to moderate risk, by the way, in a patient who has CKD stage 3 above, they are automatically considered under the high and moderate risk. And couple that with a positive biomarker, let's say in this case, NephroCheck or NGAL, then it will activate the nephrology rapid response team. Now, since we don't have NephroCheck here, we might want to use NGAL, and this is a proposed way, an algorithm, how to use NGAL. So we can score it from 0, 1, 2, 3. 0 meaning to say that the tubular damage is unlikely, 3 there is severe tubular damage, and we see here the numbers that we have been saying. So when there's a change of about 100, or when the absolute value is above or equal 150 above, then tubular damage may be possible. And basing on this score, we come up with our clinical decisions based on what we would do on several parameters. So as you can see here, one maybe of the changes is that if you think there's already tubular damage, then creatinine may be requested more frequently, and that the urine output would be checked uh, constantly and recorded. Nephrotoxic agents will already be adjusted or shifted. Whereas if, let's say, the biomarkers would point that tubular damage is unlikely, then we may continue using NSAIDs, and maybe we don't have to be very particular about the urine output so as not to strain the nurses. And if you put it in algorithm, this is how it's going to look like. This is an old algorithm. That's why here it even gives us a trigger for doing kidney replacement therapy, though there's really no evidence of using, at this time, biomarker as a way to decide whether kidney replacement therapy has to be initiated or not. So a more modern version of that would be here, but this is based on the use of NephroCheck. So if in case the nephro team comes in, stratifies the stage, avoid its further evolution, finds its cause, and then even to the point of following them up at hospital discharge. Now, has this been done, or it's just all in theory? Well, it has actually been done, as shown here by one of those who are pioneering this biomarker based algorithm in Bay State Health Hospital, by Dr. Engelman, and he shared with us how their hospital would respond to a positive or a negative nephrocheck. So in case of nephrocheck, they use a cutoff of 0.3. So when it's less than 0.3, as you can see, they can allow the use of NSAIDs. They remove the Foley catheter. They may recommend transfer or downgrade to a telemetry unit. Whereas on the other extreme, if they think that the risk of this patient is very high, they would resort to a goal-directed therapy by monitoring pulmonary artery diastolic, but which in our case here we're using pulmonary capillary wedge pressure, and to give diuretics in accordance to these numbers, or to give volume resuscitation based on the numbers of this test. Now, moving on to consensus statement number 8, inclusion of biomarker data with clinical assessments can be used to identify patients who will need kidney replacement therapy and facilitate optimal timing of initiation. I did not really see any evidence on this one, and I think that we have not, there had not really been any that has been done on this matter. Okay, finally, on the fourth area of interest, and we're almost finished. So this is now the 9, 10, and 11 consensus statement. We suggest that novel biomarkers can be used for prediction of duration and recovery of AKI. Currently, there's insufficient evidence to recommend the routine use of novel biomarkers to refine acute kidney disease staging. And we recommend that biomarkers predictive of CKD staging and progression be incorporated into a comprehensive post-AKI or AKD care bundle and KAH. AKD staging for the residents would mean that acute or subacute stage or loss of kidney function from day 7 onwards up until 90 days. And that consensus statement 10 probably came from this study by Kerr, wherein when he checked about 38 biomarkers to look into progression of acute kidney injury and found that despite having a very complicated statistical machine to predict AKI progression, that it really did not offer anything new in terms of predicting AKI progression. And when it comes to renal recovery, there's only one right now biomarker that has been tested on this aspect, and this is the nephrocheck, wherein what they did was to assess the concentration, the relationship between the decline in the concentration of this biomarker from 4 and 24 hours after surgery and to renal recovery, which is defined as serum creatinine value at hospital discharge, equal or lower that to the baseline. And they found that compared to NGAL, which did poorly at 0.48, the curve for Team 2 IGF BP7 was actually 0.79. This is a study by Mal Elroy. It's a prospective observational study in one academic center, basically looking whether the use of biomarkers can predict in-hospital mortality or eventual need for kidney replacement therapy. So this slide just shows, and what he did was to couple the change in serum creatinine with that and compare and then combine it with the level of urinary NGAL. And the, basically the slides here would just show, I would just like to show you how different it is in terms of change between somebody who has an outcome versus the one without an outcome. So the outcome here we're pertaining to mortality or KRT, kidney replacement therapy, and this is for NGAL. And when he combined the results, it showed that the urinary NGAL measured at 18 to 24 hours, as you can see in the odds ratio here, um, increase the prognostic utility of just using serum creatinine to predict in-hospital mortality or the need for. And he actually extended the study to include other urinary biomarkers. There are actually 4 urinary biomarkers that he included in the same subject population just to see whether that will again improve the predictive performance. And actually what he did was like a scoring system. So he had the 4 urinary biomarkers, he combined it with the urinary NGAL, and he combined it with the change in serum creatinine and showed that in terms of predictive ability, there's actually an improvement when you combine. But always, I think the barrier to doing all this is the cost and the accessibility to these biomarkers. So is it just immediate in-hospital mortality or kidney replacement therapy, or does the value that this biomarker give us extend up until 3 years or 5 years down the line? Well, this is a study, it's a German study published in 2018. It's multi-center that involves 200 patients with a primary endpoint, not just of acute KRT, but also outcomes 5 years later using urinary NGAL as one of its biomarkers. And it showed here for urinary NGAL, as you can see clearly, these are those who are NGAL positive and who satisfied the AKI diagnosis using rifle, that compared to those who are NGAL negative but rifle positive, NGAL positive, rifle negative, or both are negative, that you can actually see here um, that these patients did poorly even 5 years later. And you can see that the line starts to diverge as early as 6 months post follow-up. Of course, the one who are NGAL positive and rifle positive did worst. This was confirmed by another study, this time in the Chinese population, um, showing that, but this time using cystatin C, and it showed that when there is a 30% increase in cystatin C, there is a high that it is that there's a higher Cleveland score, and that it is an independent predictor of major adverse events, as shown here. So this is for the major adverse events after 3 years of follow-up. And when they combined both using cystatin C and serum creatinine, you can see that the odds ratio is higher when the biomarkers are combined. Such that basically what all this tells us is that the potential benefit or how biomarkers might help us is really in the recognition, the earlier recognition, the earlier awareness and treatment of possible injury that's already happening. And instead of having a lot of questions, we may probably have more answers. So as a takeaway, so is the use of novel biomarkers in cardiac surgery just a conceptual paradigm, or is it ready for use? In these broad areas of interest, we see that for risk assessment, NGAL and cystatin C may be used, but remember that their predictive capability is only improved when you combine them with the validated scores like Cleveland and Euro scores. In terms of prevention, the use of NephroCheck 4 hours after cardiac surgery led to a 17% reduction in AKI. However, it's not available in the Philippines. In terms of diagnosis of CS-AKI, we note that standalone biomarkers probably wouldn't work, and that we should be using combination biomarkers, combining both damage biomarker with functional biomarkers. And in terms of management of AKI, it's something that excites us, something that we look forward to have a nephrology rapid response team. And when it comes to predictions of acute, when it comes to using these biomarkers for initiation of kidney replacement therapy, there's no evidence. But as a prognostic marker for KRT, major adverse events 3-5 years down the line, yes, there are evidence to point that the use of biomarkers can do that. And even with renal recovery using specifically TIM2 and insulin growth factor binding protein 7. And that, I think that the elusive kidney troponin that we are looking for is not a single biomarker, but it's actually a combination of biomarkers that will complement rather than replace serum creatinine. And I'd like to end my lecture with this quote from Socrates, that the secret of change is to focus all your energy not on fighting the old, but on building the new. So with that, thank you very much for spending your time with me.
Thank you, Dr. Selim, for the very comprehensive lecture. So we have learned a lot today. So the novel biomarkers, on the timing, on where to request the novel biomarkers, as well as on how it will affect our management. This lecture has also been one of the most attended lecture that we really needed to extend the capacity of our Zoom to more than 100, as more participants are very delighted to hear you lecture. So first, let's before we go to the Q&A. So if you have any questions, you may type in your chat box, and we will try to answer it. So before we go to the Q&A, let us, as promised, let us flash the pre-test answers. so that our audience can know if they got the correct answers. So can we flash, Yani, the pretest questions? Okay. So for the first questions, the characteristic of an ideal biomarker, I think 91% got the correct answer. So the characteristic for the ideal biomarker is that it must be generated by the damaged cells and exhibit organ specificity. So for question number two, there are three types of biomarkers: the stress, damage, and dysfunction. So which of the following biomarkers is correctly matched to the type of biomarker? So majority again got the correct answer. So NGAL is a damaged biomarker. So for question number three, so yeah, this one had been a tricky question, no? So the following conditions all lead to an underestimation of EGFR using cystatin C, except majority answered obesity, but the correct answer is actually hypothyroid. Okay. So are there any questions? You can type in your questions. So I'll just read. Uh,
Rachel, yung sa number 3, just for them to remember
yes,
it,
for the
because cystatin C is found in nucleated cells. So, like in obesity, inflammation, so you have more cells because it's a state of inflammation. So more cystatin C is produced. So it would appear that it's elevated. Whereas in hypothyroid, although they did not give an explanation, but I would suppose because the metabolism is also slower, then the production or secretion of cystatin C is also less.
Thank you po, Dr. So I'll just read. So thank you, Dr. Asi, for the excellent lecture. So we have a lot of comments, very comprehensive. So there is a question of Dr. Eileen Agbanlog. So Doc Asi, from your readings, is there an evolving role of biomarkers to SLE nephritis?
I actually did not read on the autoimmune, but it might be, if ever, I think it might be cystatin C based on the pathophysiology. But I didn't read on it because I was really just focused on the cardiac aspect. But from the pathophysiology, it might come out as cystatin C.
Okay, noted, Dr. So do we have any other questions? Yeah, thank you, Doc Asi, according to Dr. ID.
Thank you very much. And really, I was trying to shorten my lecture, but I don't know how to shorten it even more.
So do we have any other questions from the floor? So more of congratulatory, Doctora, because this is really a comprehensive lecture. More of congratulating.
Thank you. Thank you very much. Okay, so if there are no questions, I think
Yeah.
nag-overtime nga tayo.
Yes, okay. If there are no more questions, so again, thank you, Dr. Asi, for the very comprehensive lecture. And I really hope that we can translate this clinical knowledge to this theoretical knowledge to clinical use. So very, very useful.
Dr.
So,
Von has a question.
yes,
It's a
Dr.
gift
Pot.
kit. Yes, it's a kit.
Okay.
I've been trying to reach out to NephroCheck just to ask if they have somebody here already or in Asia Pacific. But so far, they have not really given any reply. So, but it's something new, something for, I think it will really push the field forward when it comes to AKI and AKI prevention.
Okay, so if they're out,
Please,
I think Dr. Oscar Naidas
Anna
raised his
Grace,
hand. Dr. Oscar Naidas, yes, you may unmute po, sir.
dumating na pala ang NephroCheck. I didn't know.
Hi, Asi. That was a
Hi.
wonderful and insightful presentation.
Thank you.
Um, I just would like to make a comment on the use of serum cystatin C on recovery of AKI.
Yes, doctor.
Yeah, and while you were giving the presentation, I look for a lecture I did in 2018, and if I can just share my.
Yes, sure, Doc.
It's actually well. Anyway, it's a small study wherein patients who develop AKI and they underwent kidney replacement therapy, and they were followed up with a serum creatinine and serum cystatin C. And when they went into the diuretic phase, serum cystatin C uh, went down earlier than the serum creatinine by 2 days. So the clinical implication is if you are making the decision to continue or give additional uh, kidney replacement therapy uh, based on a creatinine, then rather than a serum cystatin C, you will be giving additional kidney replacement therapy, but by one or two treatments, because serum cystatin C would have um, gone down 2 or 3 days before. Uh, After that presentation, I think there was, at least in my part, there was this uh, change in practice of patients uh, having AKI, initially oliguric, they went to develop or need KRT, but when they went into the oliguric phase, I did the simultaneous serum creatinine and the serum cystatin C. And if I remember right, our observation also showed that serum cystatin C uh, recovered or went down earlier than the serum creatinine. And I think in the absence of the other nephrocheck parameters, this is what we can probably do in patients with AKI. Initially oliguric, they need KRT, and when they were shifting to non-oliguric phase, you can use serum cystatin C to probably predict earlier recovery of AKI.
Thank you, Doc,
Thank
for
you.
sharing that because actually I heard that from you, and there was actually also a conscious effort on my part to do that in practice. And it's just that I couldn't find the evidence on CSA-AKI. But I agree with you that when I do that, I use it as a gauge to see whether the kidneys are already recovering. Always, cystatin C would come down earlier than serum creatinine. And I've actually had several patients wherein I've relaxed towards like during the course because I know that the serum cystatin C was already coming down. And sometimes lost to translation, like the fellows would wonder why medyo nagre-relax na kasi nakita mo nang bumababa yung serum cystatin C. And it's across for my experience, which is very brief and very few. Usually critical care patients when you're deciding whether or not magpo-progress pa ba yon or it's about to recover, then whether it's sepsis, whether it's cardiac, I think it's very consistent with what Dr. Naidas had said. Maybe we can start being more conscious about our own results, no, when we do it in clinical practice.
Yes. Noted po,
Yes.
Doktora.
Thank you.
Thank you. Thank you, Dr. Naidas.
Excuse me, just to clarify, even in sepsis, we can do that.
For the cystatin C.
Recovery, no? Cystatin, no? We can do
Yes,
that also.
doktora, parang when I do it but as I've said, kaya hindi ko siya minimension kasi hindi naman, I wasn't able to verify it. But I would usually do a parallel of cystatin C and creatinine. And usually cystatin C talaga it drops faster than serum creatinine.
Okay, thank you.
Thank you, doktora.
So, thank you, Dr. Goyap. So if there are no more other questions and inputs, so again, thank you, Dr. Asi, for the comprehensive lecture. So we also invite you to attend our next module. So this is on volume status assessment to be lectured by Dr. Pompeo Bautista on June 7th, 2021 at 6 p.m. as well. Okay, so thank you very much and enjoy the rest of the evening.
Thank you, Rachel. Thank
Thank,
you.
thank
Thank
you
you,
po.
everyone. Thank you.
Thanks,